Hello, and welcome to today's show. Once again, we are talking about protecting your family. Specifically, we will be focusing on the medical aspects related to one's healthcare and end of life matters should the unfortunate arise. More specifically, we'll be talking about medical aspects related to healthcare powers of attorney and living wills. Stay tuned to discover why you should plan ahead now, talk with your family, make your wishes known, and empower the right individuals to help you. I'm Jeff Rehmeyer. I'm an attorney and president of the CJ Law Firm. Historically, my practice involved estate planning administration, business, and real estate. Now, I'm emphasizing my focus on estate planning to include planning for young adults. On today's show, I'm very happy to have with us Dr. Michael Spangler, Vice President of Medical Affairs at UPMC Pinnacle Memorial Hospital. Dr. Spangler, welcome.
Glad to be here.
Just briefly, Dr. Spangler shared his resume with me, and it's very impressive. But I would say that he spent a number of years being supportive at Memorial Hospital at its prior and now current location as UPMC Pinnacle Memorial, which is a premier facility for us here in York County. By way of educational background, Dr. Spangler attended Ursinus College to get a Bachelor in Science, went to the Lake Erie College of Osteopathic Medicine, and then went to Marysville University in St. Louis for a Master's of Healthcare Administration. So we have a lot of quality education that allows you to perform as a doctor and to administer. You also have done extensive committee work at Memorial. I see a list of interesting and exciting committees, so I know that you're dedicated to others and making a difference. So thank you again for being here with me today. We're going to try to make a difference and help people protect their families.
Sounds great.
So if you could, Dr. Spangler, can you take a few minutes just to tell us about yourself professionally and personally?
Sure, absolutely. I'm proud to say I'm born and raised here in York County. I'm a proud alum of Dallastown Area High School, and I left to kind of circle around Pennsylvania in my education. As you said, Ursinus College out near Philadelphia, then up in Erie. And eventually I decided to come back here to York to establish my practice. We actually moved back into Dallastown School District for my kids and everything as well. I have had a passion for internal medicine from the very beginning. For those of you that don't know the difference between family practice and internal medicine basically takes a patient from 18 years of age and through death. And really what we do is we specialize in chronic disease management. And throughout my career, I first started as an outpatient physician that did outpatient and inpatient. Those are dinosaurs these days, unfortunately, with the way medicine's going. You either become an all inpatient doctor or an all outpatient doctor. My passion leads me to the critical patients in the hospital. That kind of interests me. I love the intensive care unit. I love taking people from very sick to watching them walk out of the hospital in the best situation. And then the leadership bug hit me. It's funny. I think some people look for leadership, other leadership finds them. Throughout my career, I kind of found the right situations, I think, that led to my passion. And in 2016, I started up the hospitalist program here at Memorial. Actually, it was at the old site, but eventually transitioned to here. And about 3 years ago, I started as the vice president of medical affairs here. So I feel that as leadership leads you, you can touch more people. I no longer have that scope of just the people I have. Now I help to guide other physicians to touch a bigger swath of patients.
That's outstanding.
Thank you.
We're sitting here at a law firm with 32 attorneys in the building, trying to help them help others. I understand and appreciate the magnitude of what you're doing, especially with it being in medicine. And I do admire your dedication to Memorial. I have been and continue to be a fan, and am a fan of UPMC as well. Just briefly on a personal level, since the show here is Family Matters, tell me a little bit about your family.
Okay. My family goes a ways back here in York as well. My father was a Central grad. My mom was a West York grad. I have a grandfather that graduated from William Penn. Both of my kids, like I said, are in Dallastown as well. We have a very vested interest in York. Like I said, I think I think it really means something to me to do my education elsewhere in Pennsylvania and come back and be able to provide medicine here in my hometown. I think it makes all the difference in the world. I told people in the past that I just speak the language really well. Being born and raised here, I can speak York pretty well.
There we go. Know all the traditions, have the pork and sauerkraut, and New Year's Day. Good.
You got
it. So since you're a doctor and an administrator, help me understand, what does a typical day look like for you at UPMC Pinnacle?
Great question. One of the things that I really pride myself in is being an administrator of the hospital, but still being a bedside doc. A couple days a week, meaning about 6 or 7 days a month, I still see patients in the hospital. It's important to me to be rooted back with patients. So today, as a matter of fact, I actually am taking care of some patients in the hospital even now. Otherwise, a lot of my stay deals with patient concerns, complaints. I do a lot with our quality team, how to assure quality in our hospital. One thing people don't know is quality is governed by our medical staff. Being a member of the medical staff means that you're dedicated to the quality of care that you provide. So I run a lot of those committees and programs, and when there's concerns, we take them forward. I'm blessed to have not only great leadership here in the administrative level, but throughout our organization and support the whole way from not only here locally at here in York, but up to Harrisburg and definitely out to Pittsburgh as well. One of the coolest things that we do now is all about telemedicine. We have exposure to those the one of the biggest academic sites in the state of Pennsylvania, and getting the experts of experts to be able to reach out to, like you and I are talking today. It really brings a special degree of expertise to the bedside that a community hospital typically can't do.
You almost got into my next question preemptively, but so you're saying the telemedicine benefit, if I'm at your facility here in York and you need to call on somebody with extraordinary expertise at UPMC out of Pittsburgh, you can do some sort of teleconference and set people up. So now I can be close, but I can still get that expertise.
Yep, absolutely. One of the best programs we have is a telestroke program, where a patient can come into the emergency department. We identify quickly that they have signs or symptoms of a stroke, and we set up a computer system right there at the foot of the bed with a stroke neurologist, and the equipment. Not only can they communicate back and forth, but the exam they can do, if you sit on the other side as the person examining, they can go straight in right up to a pupil and be able to see how reactive a pupil is. The technology is absolutely amazing. Then what they do is they assist with management. They say either yes, a community hospital is the right location. We want you to give XYZ as far as medications and management. Or they say, hey, you know what? You need to go to a comprehensive center. This is where we want to go, but this is how we're going to get there. So like I said, that level of expertise is absolutely amazing. We have other cases where these dissections or tumors or what have you, that we can get the people that are putting together these large scale projects to look into new cutting edge medications and treatment options. We have a relationship with Hillman Cancer Institute, which that's what they do. They groundbreak the cancer treatment, and we can actually provide that management here in our hospital. You don't have to be out in Pittsburgh to do that. It's amazing. And like I said, with the COVID pandemic, the one thing that actually came out that works for us is telemedicine. We knew about telemedicine before COVID, but very, very rarely was it used. Within a month of all the COVID craziness, we were able to multiply 100-fold the amount of cases we were doing telemedicine wise, both inpatient and then transferring it to the outpatient world as well. It's amazing. And like I said, I think we talk about all the terrible things that happened during the COVID pandemic. I think this is one thing that's going to be very positive coming out of it. To be able to, I mean, the extension for people to actually be able to see a doctor in their home on their telephone, or like I said, be in the hospital and be able to have all these experts around is really a game changer in medicine.
That's fantastic. So just to back into one thing you said earlier that I'm still a little curious about, you referred to yourself doing inpatient and outpatient work at the start of your career.
Mm-hmm.
And I think you said the word dinosaur, which is one of the words I definitely understood that you said.
Right.
Why have physicians had to switch to one or the other? Why can't it still be both?
That's a great question. And there's a couple answers to that. One of the biggest ones is time. As our baby boomers get older and more medical problems, there's more people that need to be seen. And having a practice where I used to have half a day at my office and then drive to the hospital and then see my inpatients, or vice versa.
Mm-hmm.
You can only get a certain number of patients in for a half day, and trying to do that doesn't work. And like I said, the travel time is inefficient. So what happens is you get people that get really, really good at outpatient practice and can see a lot of patients very efficiently and well. And then you have the people that work in the hospital. And one of the things that's kind of difficult is hospital medicine isn't like outpatient medicine. It changes as much as outpatient medicine does, but there's an art to it. There's an art to identifying how you start talking when a person's admitted to the hospital, start thinking about how the patient's going to be discharged from the hospital, how you transition that care to other people, who you bring into the case, rather than just having every different subspecialty of medicine seeing a patient. Who do you bring in? When do you bring them in? How do you transition somebody? When is it appropriate to be in the ICU? When is it appropriate to be on the floors? And probably to dovetail very nicely with our discussion today is when have we gotten to the point where yes, we can keep a patient alive indefinitely, sometimes because of medical technology is that good. But when does care start to become futile? Or when is it that we start thinking about, well, what are the patient's wishes when we're stuck with the fact that maybe the course of treatment may extend for a short period of time? What do they want? There are some patients that say, hey, you know what? The last thing I want is to die in a hospital. Well, how do you do that? What does that process look like? How can you make it so that way the transition from inpatient to wherever they live the rest of their days is smooth, and without pain, and allows that patient to have that passing with dignity, which I think is so vitally important. Sorry, okay. I might have gone to the next question, but
well, I did share questions with you in advance, so I'm not going to fault you for thinking ahead, Doctor. So just briefly for those watching, as part of the Family Matters, part of my efforts recently have emphasized certain planning documents, and one of them, which is very important, is a healthcare power of attorney and the living will, which are often combined together and called an Advance Heath Directive. And I'm recommending and doing those for any individual once they turn 18 or older, because at 18 they're a legal adult. So I would call them a kid because I can, but at 18 they're legal adults, so non-minor children. And I emphasize completing the healthcare power of attorney and living will in advance. And within that healthcare power of attorney, you would empower somebody else, your agent, to make medical decisions for you if you are unable to, and in accordance with your directives and wishes. And then the living will component is the part that comes into play if you're faced with an end stage medical condition that will result in your death. And as you alluded to, Doctor, when does that death occur if a hospital is otherwise able to prevent it?
Right.
So maybe talking about those documents, can you let me know at the hospital how many people show up with healthcare powers of attorney, how many people don't, what that looks like at the ground level?
Yeah, I wish it was a lot more. I can tell you that. I was just on a call last week where this subject was brought up, and it was people from all over the country. And you have hotspots. You have a place down in West Virginia that has as high as 50+% of patients that come into the hospital that actually have a living will or a durable power of attorney. You have places like Missouri where only 10% of the people actually have these documents done. We're probably somewhere in between that. I have to be honest, though, the one of the biggest problems that we have is if you're waiting until you get sick and come to the hospital, you're a hair too late at that point in time. I find that really our outpatient providers really should be addressing these things. It's best to address who you want to help in that decision making and how you want that decision making to be done when you're healthy. Because when you're not healthy, you might not be thinking straight. When you're sick, you're not thinking straight. So identifying who's going to act on your behalf when you can't speak for yourself. I think COVID, I keep on coming back to it. I don't think I can talk to anybody these days without at least mentioning it 5 times during any talk. But I think COVID brought that to the forefront. And the reason why I say that is we haven't seen in recent generations healthy people getting sick to the point where they're looking at death. And COVID did that. We had 30, 40, 50-year-olds that were completely healthy with no medical problems that were coming into the hospital and getting sick to the point of dying. And that escalates these questions even more so, because we had people that would come into the emergency department, would be put on a ventilator, and all of a sudden now they can't make the decisions on their own. And you find out that maybe their immediate loved one, whether it's their spouse or their child, is probably not the right person to make that decision. I mean, we had patients with the next of kin, if they didn't have a spouse, was a 14-year-old child. How do you make that decision? And these are decisions that we can make consciously ahead of time to say, hey, this is the person that I designate to make these decisions when I cannot make these decisions on my own. I mean, we know in our scope of persons that we live with and we care for, who would make those decisions. And I think one of the most important things when you're looking for that person is you need to have these discussions that say, hey, this is my wish as a patient, or when I become a patient, that I want everything done for me. If I get to the point where I'm on the ventilator to the point where I want to be a tracheostomy placed, and I am comfortable with that quote, living on a machine, you need to state that. But I got to be honest, most of us don't necessarily want that to happen. Now, COVID was interesting. There were people that were 21 days on a ventilator that got off of it and did very well. But that, again, this generation hasn't seen an illness like this before. Previously, if you were on the ventilator for more than about 7 days, we were talking about, okay, well, the long-term prognosis for this patient doesn't look well. COVID has changed kind of the way we do that. But like I said, it's so important to make sure that when you choose somebody that's going to be your power of attorney, that they stick to the script. And that doesn't necessarily mean the living will, but to have that discussion that says, hey, if there's a chance for recovery, go for it. Do everything you can. But if I get to the point where I'm going to be dependent on machines, maybe you don't want to do that. And you need to make sure that you pick the person that can make that difficult decision, because one thing's for sure, the most uncomfortable side as a physician in that whole scenario is we can only give you information. We can't make that decision for you. Like I said, we as physicians want to go, let's go. Let's try to make this patient better. That's what we want to do. That's the oath that we had. First, do no harm. That's in that Hippocratic oath that we do. But the real story lies is what does the patient want? What do we want if we're faced with those situations? So, like I said, I think that addresses the first part of that question that you had as far as that power of attorney is concerned. Is there anything else you want me to touch on there with power of attorney?
Yep. So if I just unpack a little bit what you said.
Yep.
If you're in a facility and you can't speak for yourself, your agent under the healthcare power of attorney will speak for you. And ideally, you want to have a discussion with that person well in advance of an illness so they know how you'd like to be treated, what your preferences are, and then they can interface with the physicians who provide the information and take that information and implement your wishes.
Exactly. And I think it's important that you let your family members know that as well. It's not anything against any of your family members that, oh, I'm picking my daughter rather than my son, or I'm picking my son rather than my wife. It's not that. It's let's have a discussion. This is who we feel should make that decision, and everybody should agree to that. Because one of the other difficulties that we have is if that discussion hasn't been had ahead of time, you get into the hospital and the emotions of the situation really start taking stage. And we're at some point, we get to the point where we're not thinking of the patient, we're thinking of the family dynamic, and that causes all kinds of problems in care of the patient.
So the talk, in addition to helping you select the right person and convey your wishes, also can make things better for your family. When you're in the facility, you may not know what's happening around you, but they're the ones that have to deal with it. So it sets those expectations, it sets that framework so they can get along better.
Absolutely.
Okay. Just so I know, if somebody comes in without a healthcare power of attorney or living will, how does the hospital handle that?
Great. Typically what happens, at least in our facility, is these questions should be asked on registration when somebody's getting admitted to the hospital. We ask, do you have any advance directives, including living will and designated power of attorney and all those kind of things? If you don't, the follow-up question is, do you want information on it, and do you want help to start getting those documents in order? So it's our responsibility to pull that information out. I think one of the difficulties is when somebody has gone through the efforts to put together these documents, or to make things official, have lawyers draft all this stuff, have the signatures and all that, and they don't have the paperwork with them. In this day and age, we rely on that black and white document with a signature on it to really kind of guide our care. So I tell people that once you've established these documents, you need to bring them. And just because you brought them to the hospital the one time and they put it in their record, don't assume that it's going to be there. Every single time you go in, you should have those documents with you, or make sure that person that's going to act as your power of attorney knows where those documents are, so they can have them and be there at the bedside quickly in a timely fashion, put it that way. Yeah.
Doctor, it makes me smile to have heard you talk about telemedicine a few minutes ago, but now you're saying bring the paper. Because as a lawyer, I still like the paper. Interestingly, it's probably been over 20 years since the Uniform Electronic Transactions Act was passed in Pennsylvania, supposedly to decrease paperwork, but it carved out two primary areas where hard copies still matter. One is estate planning style documents. The other is actually real estate. And I would say that our practice, when I do a healthcare power of attorney with somebody, is we actually do 4 originals. And I specifically do them with blue ink so you can tell a copy from an original, and they're witnessed and they're notarized. And the form itself is not necessarily a hidden or magic form. A lot of it's guided by state law, and we don't deviate too far from that, so that when one of our clients comes in with one of our healthcare powers of attorney, you or somebody else doesn't look at it and say, what are they trying to do here? You recognize it and it serves its function, but there are just certain things you keep with you, and that's one.
Right.
So,
right. The interesting thing about the living will itself is a lot of people don't understand when a living will actually comes into play. They think that, okay, we bring this in, oh my goodness, my loved one needs to be intubated because they have a bad pneumonia. They don't want that. See, that's on this paper. And the fact of the matter is, it's not. It's when it's end of life situations. It's when the person can't speak on their own behalf. I mean, that's when that document becomes important. And we certainly do not want that paperwork to say, hey, in a potentially reversible situation, this person some people feel that way, but that's very infrequent versus the more frequent. Hey, if I'm at end of life, I don't want to go through the lines and the tubes and everything else, and live the rest of my days that way.
What's interesting, so we're going to talk again next week, same time, same place. And next week, we're going to go deep into medical conditions that may trigger the provisions of a living will. And I would tell you that when I meet with clients to sign them, I often get a lot of questions about the practical application. And it's interesting to me because some people are concerned that a living will is applied too quickly. And I typically say the paramedic's not looking for it. Even the emergency room doctor's not looking for it. It's somewhere beyond that. But then I have other people that say, I don't want to linger too long. So next week, we're going to get into that very deep, and I'm very excited about it. For purposes of today, just a few more questions on these topics. When we spoke before, you talked about a personal experience you had relative to your father in the conversation. Could you take just a few minutes and highlight what happened and what you learned from that?
Of course. Yep. There's two sides to this. The first side is about a year after my father retired. He was out working out at a local gym and had a cardiac arrest. There were two, I'm going to call them good Samaritans. I can go into the whole detail, but I won't go into the detail in this talk. But they were able to revive him because they knew that there was an AED in the gym, and he was resuscitated. He came to the hospital. We didn't really know what was going on. He went to the cath lab. They were able to do wonderful things. And I can remember going in and having that discussion with the cardiologist saying, we're not sure if he's going to survive this. And all of a sudden, to me, that moment of realization of mortality and morbidity in my own family really kind of hit. Now, fast forward a day, because right after we said, not sure what's going to happen, he came out of it. He actually ripped the tube out of his mouth. I won't no details to that, but and he did fine. He actually survived an episode that if that would happen even in the hospital, I'm not guaranteeing you that you would do well. He actually not only did well, he resumed his normal state of health as though nothing was going on, and he lived a very fruitful life for the next 10 years. So there's a good example of where a living will wouldn't happen. We wouldn't do that. We don't know what's going to happen. Okay, you got better. Great. That's what we want to occur. Now, fast forward 10 years. My dad was then diagnosed with lung cancer. Unfortunately, when he was diagnosed, it was very advanced, and his treatment options were few. He said, "Yeah, let's go ahead, let's give it a shot." And unfortunately, with it, I don't think it was even a year on therapy where the therapy just didn't work. He continued to progress and didn't do well. Now, one of the most important things, though, is a couple. Number one, we cheat as a family because I get to be the medical person in the family, and everybody kind of understood that. So designating a power of attorney, that was kind of easy in our world. What wasn't easy is that discussion about what do you want. Cancer is one of those that we'll talk about next week. In when do you enact a living will at those situations? Because, like I said, in a physician world, we want to make people better, and we tend to be very, very aggressive with the way we do so. But I can remember multiple conversations with my father when he said, "Mike," he said, "do what needs to be done, and you know what needs to be done. However, I don't want to be hooked up to machines forever. If things aren't going well, I don't want to continue to be in the hospital more times than I'm not." I mean, he was a robust, life of the party, active guy, loved to play golf, especially when he retired, probably more times than he should have, 5 or 6 times a week, if he was given the opportunity. But he made it very clear to me what to do in those situations. Then when he got very sick, he required what they call a BiPAP mask, which is a tight-fitting mask to his face. And the doctors came in and said, "I don't think we're going to be able to take this off of him because the tumor had gotten to that point." He was completely lucent. He was able to identify my kids when they came in to visit, my mom, myself, my wife, my sister. But I knew what his wishes were. And at that point in time, we made that very clear with the living will with us that said, we're done. He does not want to be intubated. He does not want to be left with this pressurized mask on his face for the rest of his life, because that's not a death with dignity type of situation. So what we did is we made that switch to morphine, which is a pain and respiratory drug, depending on how you use it. We transitioned him to regular oxygen because you don't want to be starving of oxygen, but we gave him that. And for the next couple of days, we saw him peacefully pass. Death with dignity is what he wanted. And at no point in time throughout that process did I, my family, anybody who knew him, feel that we were not doing what he wanted done, because he was able to go and pass in a way in which he felt comfortable. Now, do I wish that he was not in the hospital when he died? Of course. I wish he was in the comfort of his home and all that kind of stuff. Unfortunately, he was too unstable, and we couldn't guarantee his comfort, so we chose not to do that. But it went down the line exactly the way we wanted. I can remember while he was on his morphine drip, one of the times when he looked over at me kind of with his idea of, okay, Mike, I'm not gone yet. But and it like I said, it was a wonderful time to reflect, to celebrate his life, to make sure that, I mean, yeah, we shed tears and all that kind of stuff. Nobody wanted to see him go, but we wanted to remember him as him, not as somebody attached to a whole bunch of machines. So like I said, we literally as a family experienced what I term almost a medical miracle, which people talk about the first time. And then the true reality of what would have been futile care if we didn't have those discussions when we did. So like I said, I think it nicely shows both sides of that discussion.
Thank you for sharing that.
Of course.
So a few things that I heard you talk about. One was that death with dignity and allowing your father to pass in the way he wanted to pass and preserving those memories. And then you talked about futile medical care, which to me also would be wasting resources to some degree that could be otherwise used in another way, whether it's financial resources to benefit one's family or care resources that could be used for other patients if there were limits on that.
Absolutely.
Okay. All right. What I learned a lot from what you said. Is there anything that you would offer anybody as practical advice from your perspective as a physician relative to the healthcare power of attorney and living will documents?
Yeah, I think the one thing that I would like to pass on is don't be afraid to have that discussion with your family doctor whenever you want to. Like I said, I think we as physicians need to be better about it. Like I said, we in the medical world get very locked into, we're just here to make people better, to identify what the problem is, give you a couple pills, and life is good. Well, unfortunately, life doesn't quite work that way. And in medicine, we really rely on that relationship, but from one's primary care physician to the patient, that is close enough to have those difficult conversations and bring in people when they need to. But discussing these things with your physician is huge. And then the physician more than likely is going to say, okay, now we need to get the legal representatives involved to actually draft up those documents. But that triumvirate to have those discussions is so important, right? The medical professional that can sort through a little bit of that jargon, because on those living wills, normally there's blood transfusion, there's antibiotics, there's fluids, there's tube feeds, there's so many things on there that unless you're in medicine, I don't know. Let your doctor kind of guide you through that. And from a law perspective, let's make sure that the document really kind of reflects what your wishes are, and make sure that you have the right things signed, sealed, delivered. That way it can be done the right way. I've had people that literally on their way into the hospital, they try to draft something on a piece of paper and sign it in the bottom. That's not the document we're looking for. I mean, in that 11th hour, the brain doesn't work the way we want it to, whether it's from infection, whether it's from oxygen, whether it's from whatever. So it's so vitally important to rely on that group of people to make sure that what happens to us, we're in charge of that. We are the ones that govern that process. And the only time to do that is when we're healthy, when we can. I can tell you, my wife and I both did ours. And it wasn't long after my dad passed, I got to be honest, when we did ours, because of that realization of, oh, wow, one thing can happen and the world can be turned upside down very, very quickly. So like I said, I have those difficult conversations. Don't be afraid to bring them up, and you can always change them. I mean, you have that document, right? And things may change in your phase of life. Like I said, you may get to the point where you end up with a diagnosis of cancer, and all of a sudden your belief changes a little bit, or you designate somebody as the power of attorney, and let's be honest, we all have families here. That dynamic can get a little weird too. You can change that also legally. So, like I said, don't be afraid of changing things. You're allowed to. You have to do it legally, but don't be afraid of changing things. But most importantly, don't be afraid. Don't leave those discussions and questions unanswered. You got to be an advocate for yourself, and those things you got to ask, you got to reach out for, especially if somebody's not reaching out to you to help you through that.
I totally agree, Doctor. Interestingly, when we spoke earlier, we talked about some of these talks as the elephant in the room, but the truth is, if you tackle that elephant, if you have the talk, I think it sets you up better if something happens. And nearly all of my clients, when they complete documents, evidence a sense of relief that they accomplished it, and they're happy it's done. And to your point too, I do remind them that the documents don't have to stay that way forever. They can be updated. It's not 25, 50 years ago where documents were typed or handwritten, even longer than that. Updates can be done as your situation changes and as your thoughts change, but have the talk, get the documents done right, protect yourself, protect your family.
Exactly. Couldn't have said it better.
Well, thank you for joining me today, Dr. Spangler. So next time around, we're going to get further into the medical weeds, particularly following you, to talk about more specifics on conditions that may or may not trigger the implications of a living will, how they're analyzed, how they're utilized. So that will be our next episode, which will be next Tuesday at 9 o'clock. But for now, I would thank you very much for your time and your expertise. You're a credit to Dallastown, all those schools you went to, and UPMC. So thank you very much, Doctor. Have a great day, and go treat those patients.
Sounds great. Thank you very much for your time.
Thank you.